these ideas. I talk about that PG student, Department of Conservation Chemistry and Aeronautics.
And I took that as a intern.
Welcome you all as your presence adds warmth and significance to this gathering.
Our Conservative and Aeronautics department focuses on preserving national teeth through various treatments, including restorative procedures and root canal therapy. One key aspect within this domain is achieving efficient restoration through direct composite techniques. Direct composite involves using two-color materials to restore damaged or
Thank you, Dr. Radha. Good morning, one and all. I would like to take a moment to welcome everybody here, Dr. Shaikh, and all others who have spared valuable time for this enlightening event. I will take the opportunity to introduce our guest speaker today. Dr. Shaikh Khalid is an alumnus of ITS Dental College, Kolkata. He has been extensively involved in continuing dental education programs. He has presented at various state and national conferences and conducts continuing dental education programs in general and aesthetic dentistry. He has undergone training in direct and independent restorations at International Center for Dental Education, Ayodhya, Riverdale, Liechtenstein. He is a certified clinical mentor for Ayodhya, Riverdale, India. He is an active member of International Center for Dental Education, Ayodhya, Riverdale, India. He is an active member of International Center of Dental Education. He has mentored various aesthetic dentistry programs for students across India, as well as from countries like UAE and Afghanistan. He actively participates in national and international specialty conferences. Currently, he is practicing in Delhi. Aesthetic dentistry, material science, and endodontics are his special areas of interest. We are fortunate to have him today among us for his insights about the direct and aesthetic restorations in dentistry. We are also thankful to Ayodhya Riverdale for sponsoring this event, for organizing it and making it possible for us. Thank you so much. I now invite Dr. Shaikh to please take over the event.
Perfect. So, good morning everyone. Welcome to These are professors, HODs, and students who are sitting on this hall for the presentation on composite specifications. First of all, big thank you for the entire management team for making this possible. Secondly, I just want to say that the presentation challenge is something that should be dialogue. Means that you should interact with me as much as possible. Right? I can come, I can deliver, I can go back, but that will just a monologue. So ask your questions, ask your queries, ask your doubts, then I'm more than happy. And the presentation challenge today is the kind of presentation which will need to understand the art and science of how to composite relationship with negation model. It has A to Z of everything that you should know about composites if you go ahead with the implementation model. I've already introduced. Thank you so much for the introduction, Doctor. So before, without wasting any time, let's go quickly to the presentation. Okay, perfect. First, let me ask the question. Whenever you do a composite installation, why you should share every day? What are your goals? What are your aims as a dentist? Or what are the goals as a patient? And I go to our dentist. What are the demands of the patient that I can understand? Right? If I ask students sitting down there, why should they get in composites? Can I just use the composites? It's a layman kind of answer that they can give. Not exact scientific. Anybody. Why composites? Functions, aesthetic, it looks beautiful, of course, very good. I mean, it has the quality, it has the durability, but most important which we feel at times, and miss at times, is efficiency. Efficiency means that I am a dentist. I have spent 8 hours of time in a day to get a composite, right? And if my work is not efficient, I will laugh for a second, I will not feel like attending again the same procedure quite often. So my work should be efficient, should be durable, quick, and fast as well as functional in the negation model. That's why the topic efficient is aesthetics. Anyone can do efficient work, but are we efficient in the equipment? The question should be answered. Are they attempting again and again? Is the work predictable? Okay, if I do composite today, will it be functional and durable for the negation? And I wish to put in the negation model for these many years. Predictability of your work plays a vital role when you attempt a composite specialization. You should predict your work on all these, right? So if you see here, what is the step that you see you saying right now? Like as you see it clearly says that composite is something that requires different parameters to be taken into account. Starting from isolation to bonding to polymerization, material selection, armamentarium, fixation, polishing, plus maintenance. If the patient comes and follow up with problems, how should you be taking care of it? How should you be avoiding any problems or failures that can happen in composite specializations? So step that you see right on the screen, all these steps are important to know who composite specialization because as a workflow for direct composite. What is the steps that I should do? Unlike a conventional kind of amalgam glass line where it is preparation, mix, roll, and finish. Right? Where you amalgam your glass line. Here we need to address each and every parameters. I'm going to take everything one by one so that you understand each and every step how composite should be implemented in a patient's mouth. My agenda, my goal, which I always believe and I always propagate, and I always propagate in future also. So whenever you do composite, always keep these things in my mind. Aesthetics, quality, efficiency. Please don't forget efficiency. Right? Efficiency matters for me as a dentist. Right? Quality of course matters for me as well as the patient. Right? Aesthetics matters for the patient for me both. We have to address all these parameters. And how should you achieve a good kind of composition? There are lists of parameters to be taken into account. The slide that you see now on the screen, it clearly says that if a clinician and a dentist can address 1, 2, 3, 4, 5, 6, 7, whatever you you should address it. Chief company, isolation, and I'm giving scientific and non-editing. See, organization, whatever you see on the screen right now, all those require slow organization. Right? Composite is not just about isolating, according to it. Everything has to be addressed. We feel that if you cannot attend the composite in some situation, why are you doing that? What are already options? That is the reason why getting the more of the problem and understanding company is very important. Now, let me ask you a question. What is the challenge for any composite? Is it the company information or the demand of patient? What do you think? The chief company information or the demand of patient? What is the challenge for any relationship? It is demand for patient. Understand the difference. Chief company and demands. See, I have a problem. There are patients nowadays who come with an entire treatment summary. They don't even check at times what is the problem. Okay, I need this, I need that. But please tell me the problem before what you need. Well, maybe one of the things and some members what they treatment done there, or maybe YouTube, social media, or whatever, they have scrolled down and found information. But understanding the need and demand of patient is equally important if you also have to address along the CC community. Right? Second important point to note is that patients should not understand the position of the extended accessibility, disability. They don't know. It is our problem, our challenge. Okay, it says I need this, I need that. But is that why good enough? This is my challenge. Most of all, my skills, my expertise, my knowledge. If I don't have that knowledge, if I don't have that skill, if I don't have that expertise, I cannot handle it. So I keep on updating myself so that my skills are enhanced, my knowledge is improved about the topic. If I don't know something, I would rather learn from the colleague or I would learn someone to help me on my case or that situation. Last but not least, why should I do composite? What should be the agenda of the goal in my mind as a organization? Why and how I can be better in my goal? If you have a goal or an agenda, composite is just not mere about having a good white or two color as to the page model, right? There are things to do, and as the most important one is functionality to just mention, right? Aesthetics is something which is just an icing on the cake. Or cherry of the cake. But what is the cake is actually functionality. Right? So the composite should be aesthetically functional. Functional is really important. Replicating an active form, shape, color, everything. Right? What do we see today that composite is very aesthetics and analysis? You know why? Because composite replicates the aesthetics of color, shape, and form. But amalgam does not replicate the aesthetics of color. Although amalgam replicates shape and form. And it is functional, we all know that. Right? Please keep in mind these parameters, why do series, and I might ask this question quite often we do project composites, or we can composites, our goal, our color, right color, but at times we fail to give the right shape or the texture to the restoration, which is very important. Right? Last question. This is very easy. Simple. Your answer by discussion which by the points which I just mentioned. What is more important in aesthetics? Is it the shape or is it the color? What are important? I just use the shape and color. What is more important? Shape or color? From those shapes to this color. So the students see color and faculty members, teachers, they all feel like it is shape that is more important. Is this so? Both are important, but it is shape that always precedes color. Your eye will always foresee shape before color. You can take any example. Like example, if a layman is asked in his man and observe something, he or she will observe shape before color. They do not process color. Example, I'm starting this in an instance of roof. from you. Can you comment the color of my tooth? Can you see the difference in the color of my tooth? But the moment I don't have a tooth, this is you. What will your eyes see first? Your eye will perceive shape. Your eye will not perceive color. So understand. I said this because there are cases where typically this problem comes in. Example, midnight dissecting cases. What is the chief complaint of a patient? Closure space. There is something that we need to address. This problem in the shape. What we always look for, which color composition you use, which shape composition you use. Correct. Whatever color you give. But if you cannot match the individual dimension of the big sizes, that is not acceptable to the patient case of midnight assessments. Here you should say, give your original background. Always under shape, which is very important. So these things are taken into account when we go to composites. Let's go forward, understand each and every parameter in detail, and I believe that one of the most important parameters when we start composite is isolation. Everybody agrees? Students, isolation. Okay, there are different ways of isolating tools. I may use of different tools and other mediums. For example, you can use of rubber dams, which can help you to achieve absolute isolation. You can make use of electric retractors, suction contours, right? They can help you to achieve kind of relative isolation. Right? But what do you understand? What do you understand with the term isolation? Isolation means what? What are you trying to achieve? Isolation means what? What is the ultimate goal of isolation? Yes? Any student? Louder? To prevent saliva contamination, to achieve dry field. So there are two things to be understood. Isolating a tooth for an endodontic procedure, isolating a tooth for a restorative procedure like composite. Are my goals, aim and motto same in both the situations or different? If same, how? If different, how? Do you understand what did I ask just now? I want to do a root canal procedure. I want to isolate a tooth. I want to do a composite. I want to isolate a tooth. My goals are same in both the places or are they different? If same, how? If different, how? So no problem, no worries. For my endodontic procedure, usually I do single tooth isolation, right? My agenda, my goal is to prevent any kind of contamination in the canals while I am doing the procedure, right? I also don't want any kind of aspiration of any instruments or irrigants that can lead to any mishap, right? These are my goals. But in a restorative procedure, when you do composite, your major goal is to achieve dry field. When does it start? When I start to bond till final layer of composite that you place and cure, the entire field should be dry. And this dry field can be more cumbersome than your routine endodontic isolation. Right? So even if you use certain armamentarium and you cannot achieve dry field, your purpose is not solved. So understand, there are cases, there are places where I can use lipstick, retractor, suction, cotton roll. I can achieve dry field, my purpose is solved. But definitely rubber dam helps you a lot to prevent contamination. I don't need 600 or 800 dentistry, one assistant putting a cheek, one putting a suction. It also gives you a nice aura to the patient when you work alone or maybe with one assistant, not gathered by too many people around. Rubber dam helps you a lot. Long span cases of ceramic veneers or composite veneers that you attempt from canine to canine, it helps a lot. So different kinds of rubber dams are available. Conventional rubber dam comes with a punch, sheet, frame. The one that you see on the screen, other side is an Optra dam from Ivor Clark. It comes with an inbuilt frame. It does not require an external frame like this that you see here on the patient's mouth. It requires autoclave, right, after one patient to other. This is disposable, one-time use, more flexible, more comfortable. It has got an arch form drawn here. The tooth that you want to isolate punch only on that area. It's not random punching, right? And it's use and throw. Opera very nice, beautiful tool to achieve absolute isolation. Suppose if you want to go away with Opera, you want to just use conventional kind of isolation, you can get help of Opera, a very useful tool again for a lot of dentists today, which I go and meet and they say, this is something that helps a lot. It is not just a cheek retractor, if you look closely. It is lip and cheek retractor. It retracts lips along with the cheek. Right? Conventional retractors that you see, which we use made of plastic, they retract cheek, not the lips. Here you get a complete retraction of the lips as a pedo, prosto, maybe digital scanning, maybe varnish application or routine checkup, whatever you can think of, documentation, photography. You can see the tooth in the last molars, right? Even buccal pit cases, it's not, sometimes it can be difficult. You see the amount of retraction on the cheek area, right? Comes in different sizes, comes in small, comes in the junior size for pediatrics, and also comes in the large size. So in Indian patients, usually small and large both. Largeness is regular size, which the brand offers. Perfect. Next, understanding material science. There are different kinds of composite in my hands. I don't want to elaborate the brands, but I want you to understand the categories of composite that you work with, right? Can be micro-hybrid, can be micro-filled, can be nano-filled, can be nano-hybrid. What properties do they offer and which one should you be using in what case is very important to understand. So any student who can put some light, what are these composites and what are their properties which you work with your hands? Micro-hybrid composites, or micro-filled composites, or nano-filled composites, nano-hybrid composites, anybody. It's open, anybody. And why they are made like that? Why they have been developed like that?
They vary according to strength.
According to strength, okay. Nothing is wrong, Dua. You can answer. Absolutely, we are here for discussion. So please feel free to give your answers. Anything else? Yeah? Okay, particle size of filler. So what value or advantage does it add? Strength of composite. Okay, anything else? What, which category you are referring to? Which will be more polishable? Nano, micro. So this topic was something that we learned in textbooks, but we could not go into the depth. What advantage or value does it give? That happened to me as well. There is absolutely no harm. When you practice, you work, you realize, differentiate between different categories of composites, right? They were all developed as generation of composites. Today, the biggest challenge in composite that it may fail because of one property that composite holds. What is that property? Polymerization?
Shrinkage.
Absolutely correct. So if any dentist who knows how to address, how to take care of polymerization, dentist will be the right person, right candidate to handle composite in the right way. So your goal or agenda should be to control polymerization shrinkage. Unlike amalgam which expands or GIC which is passive, composite shrinks. So my goal should be control polymerization shrinkage. Similarly, companies over a period of years, they developed composite. They brought technologies to reduce lot of volumetric shrinkage in composites. Good old days, we used to have macro composites. Then came micro-filled, micro-hybrid. Today, they are all, what is composite? It's a mixture of monomers into which filler particles are embedded. Monomer and filler particles. As per ISO standards, the concentration may vary from different brand to brand. Lot of fillers that you put, it enhances the strength of the composite. Ideally, a packable composite, if you see good companies, would have 75 to 80% of filler load. Some companies may have more than that, 82% of filler load, 20% of resin monomers that gives adhesive properties. If I increase the size of filler particles, I may get a lot of interstitial spaces, right? But if I reduce the size of particles, the interstitial spaces between the filler particle is reduced, more densely packed. So if a composite does not have the space in between, the chances of shrinkage is reduced down, right? So net volumetric shrinkage will be lesser, much lesser compared to small particle and a bigger particle. So as the technology evolved, today nano composites, that we call it as nano hybrid bonds, they tend to give you a very nice restoration, having good strength, good aesthetics, good polishability, good surface luster, texture, controlled shrinkage stress, controlled shrinkage as per the ISO standards, and its handling becomes much easier, much better, consistency is better. So today if you ask me, my preference for anterior composites, or maybe for posteriors as well, would be to go with nano hybrid composites. Right? Nano hybrid composites, they have a unique property of also exhibiting chameleon effect. Has been ever told to you about chameleon effect of composites? Have you ever come across this terminology, chameleon effect? Chameleon effect is something that a composite exhibits. It takes or adapts to the environment where it is placed. Suppose composite, if I do it today, it may not have the appearance like the adjacent environment of the tooth, but it adapts the tooth when the tooth is hydrated, and you see the case of 24 hours. That is what we call it as chameleon effect of composite. All this is possible today in nano hybrid composites. Right? Then you have very nice surface polishability, surface texture, luster, working time is reduced, curing time even. Today we are in a generation where nano hybrid composite, tetric NC-RAM or tetric NC-RAM2 composites from Ivoclar, they can be polymerized in 5 seconds. Just 5 seconds with curing system, Blueface NG4 intensity 2000 milliwatt per centimeter square. We did composites back then where we used to cure composites for 40 seconds per increment. Today we are in a generation of curing composites in 5 seconds. Look at the difference that it creates. If I'm layering it, if I need to put 4 or 5 increments, how much time it is reduced, chances of making errors. Longer the procedure, longer the chances of making manual errors. Shorter the procedure, higher the chances of predictability or good outcome overall. Perfect. Based on so based on consistency, composite can be 2 types. Composite can be hard and soft, right? I usually personally prefer to work with soft composites. Reason, it is easy to mold and sculpt, right? Why? Because composite is all about giving shape and form. The harder the composite, the more difficult it is for me to give the shape, right? The softer the composite, I can mold and sculpt. Also, if the composite is hard, one more problem that you might face routinely, composite becoming sticky to the instruments. You are not able to handle composite coming back in your instrument. What happens is that composite is a mixture of resin and fillers. If you apply a lot of pressure with the instrument, the resin from the instrument, from the composite comes on your instrument, and resins are adhesives. So the composite tends to bind to the adhesive and the instrument becomes sticky. So first thing, whenever you do composite, clean with spirit on every increment that you apply. You apply, clean with spirit. Apply, clean with spirit. And do not put lot of pressure. Right? Composite is all about molding and sculpting. That is possible, and composite is softer, creamier. If it is hard, you will be forced to apply lot of pressure. Suppose if you have a deep cavity, if you have subgingival caries, so deep margin elevation, acquisition that we do, if your composite is hard, you might not know is there any void or gap that is left behind because composite was hard. If it is more softer, creamier, you can adapt it in a much better way. Chances of getting voids or gaps are lesser. Right? Perfect. Very good. So, the heart, mind, body and soul of composite is about etching and bonding. Right? There are different techniques that we follow today for etching and bonding that you see on the screen right now. It can be total etch technique, it can be selective etch technique, or can be self-etch technique. Am I right? So if I ask any student who can just volunteer and differentiate between these 3 techniques, what do you understand by a total etch technique? What do you understand by a selective etch technique? Or what do you understand by a self-etch technique of bonding? Yes. Anyone? Or do I always have to etch when I do my composite? Because this is what you have to understand. Basically, if I learned in textbook, in theory, that there are two steps, etching and bonding, where to etch, where not to etch is a dilemma, big question mark. It remains in people's head, right? What should be the protocol? That should be answered to have a good composite restoration. As I said, it is heart, mind, body, and soul. Very important part of your composite treatment. So, anybody? Okay, let me tell you. Okay, who can tell me what is the purpose of etching? Why do we etch tooth? Yes? To increase the surface area of the tooth. What is tooth? Tooth is a combination of enamel and dentine. Enamel is inorganic in nature, right? It is very smooth and flat. What do we do by etching is by creating roughness, micropores and megapores, which enhances the bonding abilities over enamel. What dentine? Dentine is rough though, because it has got dentinal tubules and intertubular dentine area. But those tubules are being occupied by smear layer that he was just referring to. So if you put an etchant over it, that smear layer has been taken out and the tubules are open again, and then when you apply a bonding agent which has got primers and adhesive, hydrophilic primers go inside to internal tubules and make resin tags and forms a hydrophobic receptor on top to which composite comes and adheres. That is the purpose of bonding. So if you go into the deep and understand, dentine is much softer compared to enamel. So etching time is very important, right? If I etch tooth, example before composite, I will follow protocol to etch enamel more compared to dentine. I would etch dentine to a lesser extent, even if I am doing technique called as total etch. Total etch means you apply etching over enamel and dentine both. Usually what I follow in total etch technique, if there is dentine involvement, dentine should not be etched beyond 10 seconds. 10 to maximum 15. 10 is where you should stop. But enamel can be etched up to 15 to 30 seconds. Right? If you etch enamel up to 30, no harm. But if you etch dentine up to that limit, it may cause a lot of damage. It may lead to bonding failure, it may lead to other problems that dentine can give you and lead to composite failures. So what do? I always start with enamel. Apply agent over enamel. Application time would be 2, 3, 4 seconds. Wait for 10 seconds. Take an agent, again apply over dentine, wait for 5 seconds. So enamel is etched for additional 10 seconds and dentine is etched for lesser duration, and time is very critical. Even if you follow the total etch technique, right? Cases where you have class 1 carious lesion having a lot of enamel, less of dentine, or you have direct veneering cases, composite veneers, laminates, or ceramic veneers, my technique is always total etch. Right? But when I have a lot of dentine involvement, less of enamel, or unprepped enamel on surface, I will prefer going with selective enamel etch and using a universal bond which acts as a self-etch bonding agent over dentine, which does not require etching dentine. It is self-etch over dentine. Lastly, the self-etch technique where you have a lot of dentine involvement, little bit of enamel, you can give bevel and directly use the bonding agent both over enamel and dentine. All these are possible when with one generation of system, which we call it as universal system. Universal system gives you a leverage, gives you an advantage to use it in all techniques, total etch technique, selective etch technique, and so it is my choice, depending upon case, whether to etch, whether not to etch, depending upon case I'm doing. It may be not necessary to etch all the time for me as per my case and the patient situation in the tooth. Right? So if you see the picture right now on the screen, these are bonding systems evolved. 4th generation, 5th generation, 6th generation, 7th generation of bonding agent. Still, the 4th generation is the gold standard that we consider. We etch it, apply primer which is hydrophilic, apply adhesive which is hydrophobic. But it takes time, multiple steps. What we did was we evolved one step ahead where we mixed primer and adhesive into one component which is total etch bond, which is 5th generation of bond. Single component total etch bond, which you all must be aware. Etch the tooth, apply the total etch. Then there are further modes. I had sixth generation of bond, where you have acetic primer in a separate bottle and adhesive in a separate bottle. You mix them together and apply. Then you have all-in-one component, where actually it is not 37% phosphoric acid, but a monomer which has the acidic nature, or a phosphate monomer, example MDP, that is added to make the bonding agent self-etch, or that makes it universal. So if I ask you, any student who can tell me what is the difference between the sixth generation of bond and a seventh generation of bond? We know that we have fifth generation of bond, we actually apply it. But what is the significance of the sixth generation of bond? Both are self-etch. But why this system? Any student? Is there any difference, or where they are indicated? Have you come across any system where you have two bottles and you mix it and you apply it? Have you ever seen such system clinically available by any brand, any company? Or why they are important in industry? Let me tell you, that is the system. That is a system that is ideally a self-cure or a dual-cure bond. So look clinically now, a self-cure or a dual-cure bond, where you can use it where light cannot go. Example, cementation of root posts, cementation of glass fiber posts. I cannot penetrate curing light inside root canals. I need a bonding system that has to be self-cure or a dual-cure. The role of sixth generation of bond comes into play. Cementation cases of all ceramic materials, maybe treatments of onlays, inlays, crowns and bridges. If I follow resin technique, resin cementation technique, my preferred bonding system would be a sixth generation of bond. Example, Ivoclar provides that in system called as multi-link resin cementation kit. We have primer A, primer B there. They both are base and catalyst. They both come together, react, and then you apply. The entire system is self-cure. Right? That helps you a lot in cases where you cannot light cure. Right? Perfect. Let's move forward now. As I said rightly, right indication will help you to do good kind of treatment. Total edge technique, usually we have when you have a lot of enamel, veneer, dystema cases, class 4 fractures, we have a lot of enamel. But if I have a lot of dentine, I would prefer going ahead with my self-etch technique, or rather I would prefer the selective enamel etch. This technique has to be understood in detail and then attempted depending upon what are you doing. So this is how it works. In total edge technique, over dentine, you have a smear plug where in a self-etch technique, there is a modification of smear layer, where in total edge technique, smear layer is removed and the bonding agent goes inside forming the resin tag. Total edge, self-etch, two different techniques. Over dentine, both works over dentine. Total edge as well as the self-etch technique. Okay, so let me give you an example of the self-etch bond and universal bond which I use into my clinical practice. It's called Esthetic N bond, universal from Ivoclar, comes in the bottle form of delivery, comes in the pen form of delivery. One of the advantages that it gives, which I feel is very good for a clinician, it has got a desensitizing effect, right? So all the sensitive cases where you are worried about sensitivity, when patient comes up with a lot of sensitivity, cervical abrasion, right? Even the air that the patient breathes feels, right? Deep case lesions, all those cases I would prefer universal bonds in self-etch technique, right? Why I prefer the pen form of bonding from Ivoclar is because it has got a uniform thickness from the first drop to the last drop. So we know that bonding agent comes up with two components, solutes and solvents. The solvents are the ones that drag those solutes inside the dentine. And those solvents are ideally acetone, ethanol or water. Are you aware about it? So acetone has the ability to evaporate faster. The chances of phase separation can be higher in acetone-based bonding agent compared to ethanol and water-based bonding agent. So this system is acetone-free. You need only single core, right? And the film thickness is remarkable, less than 10 microns. Color of bonding agent is slight yellow, which has camphorquinone initiator. When you light cure it, it becomes translucent completely. So the aesthetics while I cement my veneer is not hampered. I have compared all bonding agents from different brands. What I found out was, out of all, this has got the best appearance after light curing. I don't want to take the brand names of different companies, but I see that a lot of bonding agents which has a thicker consistency and which has a little darker color. So if I want to do a veneer, right, if I apply, first of all it acquires a lot of space and has got a dark yellow color. So when I cement it with veneer, what was before cementation and after cementation is completely different. Right, so the color here, as I said, it's a feature of this bonding agent. It's light yellow because of camphor to non, and after you cure it, it becomes translucent. So it does not have its own color. It will not affect the overall aesthetics of your cementation. Whether you do very thin veneer, the outcome and results are remarkable both in direct and indirect restorations. And of course, the biggest advantage, it gives you high bond strength over dry dentine as well as wet dentine. Right? Dry dentine is very difficult, sometimes nightmare for us as clinicians to handle dry areas where bonding fails a lot. So I'm just going to show you an image here. If you see, this is an electron microscope image of wet dentine and dry dentine. The penetration of bonding agent, 10 microns over wet dentine and dry dentine. Brilliant. I say that as brilliant, 10 microns. Sometimes even we fail to achieve 5 to 7 microns of penetration inside dentine. And 10 microns is just remarkable. This is an SEM image of this bond which I just showed you on the screen. Perfect. Okay, where can I use them? Composites, you can use them in core build-ups, you can use them in cementation cases, as I just said, anterior, laminate, veneer or crown. With resin cements, this bonding agent works brilliant. Example, Lincoln from Ivoclar. Then you can use it for repair, and it also works as a desensitizer in hypersensitive cervical areas. So these are multiple indications of universal bond. You can use it in any technique. Total etch, selective etch, self-etch, depending upon keys you are doing. Right? Perfect. Now, remember one important point. Universal bond. Typically, tetratic end bond universal from Ivoclar requires agitation on the tooth for 20 seconds. Right? Scrubbing, maybe a micro brush will help you if you use a bottle form. You are modifying the smear layer. This is very important. You need to agitate and scrub for 20 seconds. Right? No reapplications required, no multiple coats required. Okay, so what does bonding agent do? They bring two opposite entities together. One is hydrophilic, one is hydrophobic. Tooth is hydrophilic, composite is hydrophobic. To bring them together, you need a mediator. A mediation done by bonding agent, dental adhesive. Right? This is what it does. Very important to bring them together. And if you see the structure of composite with tetratic and bond universal, scientifically, this is how it looks like. This is my tooth, this is my composite, this entire area is dental adhesive. It has got hydrophilic primer, it has a cross-linking coupling agent, and the adhesive hydrophobic which bonds the composite. So this GMA acts both hydrophilic and hydrophobic in nature. Very important component in tetratic and bond universal. What gives it self-etch nature? I told it already. What it does, which component is responsible to give the bonding agent a self-etch nature? It is phosphate monomer, which is MDP, and this M cap is responsible for giving high bond strength on wet and dry dentine, which we just saw. It prevents the hydrolysis or breakdown of water. Dentine over a period of time you tend to have loss of water. It prevents the hydrolysis and breakdown. It prevents the dentinal hypersensitivity. Perfect. Moving ahead, now we go on to the very important part, or the concept of shade selection and layering. How you should understand histology of a tooth, how does the natural tooth look like, and how you can replicate it. Look at the structure right now on screen and understand. Tooth has a very translucent enamel on incisal ledge. We call it as an achromatic enamel. Am I right? Very translucent enamel. Then you have a translucent enamel in between and opaque dentine. So if you see this picture and I ask you one question, is the appearance of tooth same all around? Is it same? It's different at different places. We call it as polychromatic nature of tooth. What do you call it as? Polychromatic nature. So if you want to achieve good aesthetics, you want to replicate tooth polychromatically. As per the nature of tooth, I have to replicate the translucency of enamel. I also have to see the opacity of dentine if there is dentine involvement, if I wish to restore dentine. Right? Then these points has to be addressed. And we also need to find which shade, what will complement my work, what is there in my hands. To understand this, you should understand the concept of color called as hue, value and chroma. Furthermore, translucence, opalescence, incisal halo. So these are extensions. But basically, to understand color, you need to understand hue, value and chroma. I tell you very frank, when I came out into practice, I didn't have enough knowledge about these things practically, although I knew it theoretically. I'll be very upfront, right? But then when you do it, when you apply it practically, you will understand what this means, right? Let's take an example. If I select A1 shade of composite, A1 from any, A1 from Ivoclar, Tetrakenceram, or A2 dentine from Tetrakenceram, or some other brand gives you A2 opaque. A2 opaque and A2 dentine is almost similar. You can have a similar kind of opacity. Some companies, some brands might offer you A2 opaque. The example, Ivoclar offers A2 dentine. Why? Ivoclar offers that dentine and enamel concept because my tooth has enamel and my tooth has dentine. So taking that into account, Ivoclar has made the enamel shades having the translucency similar to enamel and dentine shades having opacity similar to dentine, so that I am not confused. What is the translucency of natural enamel? Anybody? Natural enamel translucency? It cannot be same, it varies between 12 to 15% from patient to patient. What is opacity of dentine? Or translucency of dentine is lesser. It may vary from 6 to 8%. It is more saturated, whereas enamel is more translucent. If I have the composite shades in that range in my hand, I can replicate it. Simple? Quite simple to understand. I would like to elaborate here. Hue, value and chroma. Why? Because if you understand it practically right now, I am sure when you go out and attempt one case, somewhere today, down the line, next week, 1 month, down the later as well, we will apply it and we will do it in the same way, right? Okay. So what is hue? Is the basic nature of color. Look at this pointer. I hold this pointer, it has buttons, it has a body. Both of them have black appearance, but buttons look different and body look different, right? Appearance is different, but the hue remains same, which is black. So black, blue, white, green, yellow represents hue, right? Value is the brightness of the color, from darkness to brightness. Brightest is high value, darkest is low value. Chroma is saturation or intensity. How much light can pass through? Example, this roof does not allow light to pass through. Highly saturated. Highly saturated. But this is not bright. Low brightness, high saturation. That glass, if I pass light, it goes through and through. But light has more translucency. High value in glass, but low saturation. Whereas this has got high saturation, low value. Relate to the tooth. Which is more translucent, enamel or dentine? Enamel has high value, low chroma. Dentine is more saturated, more chroma, low value. So always remember the topmost layer of the tooth, enamel, has got very high amount of value. Whereas a layer below it, dentine, has saturation which has high amount of chroma. And if you have dentine discoloration or problems of fluorosis or pigmentation, or you want to mask something, you have to use high chroma, high saturation shade to mask it. If you use high value shades, it will not mask. And high value shades are what? Which are bleach shades. If something is discolored and accidentally you have taken a bleach shade and put it there, it is high in value but low on saturation. It will not mask. For masking, you will have to use your dentine shades. So look at this. I now understand. Ivoclar provides universal shades and dentine shades. So universal shades have translucency between 11 to what I just said. Enamel ranges from 12 to 15%. So it's somewhere matching enamel. What is dentine that you see? It is 6.5 to 7.5, which has got masking abilities. Is enamel having masking ability or dentine? If you look at the black line is masked by the normal A2 shade or the dentine shade. So dentine is more saturated, it has got capacity to mask, but this will not mask. Even if I use A3, A4, they will be more, lesser in value, but then they will not mask. Look at here. Our next picture that I'm going to show you, ivochlorophores, packable and flowable composite, they all have different translucencies. Look at here, and depending upon what you have in your hands, you can play with it nicely. Enamel, dentine, transparent and bleach shades. Out of all shades, which shade has got masking abilities? It is dentine shade. None of them can mask. They all are high in value. Example, these are all high value shades, but low on saturation. So whenever you want to mask any defect, whenever you want to do any kind of masking, always remember that it has to be done with dentine shades. And you need to have them in cases and situations where you are working over dentine area. Right? So I'll give you a situation now. Just have a look at the case on screen right now. And now look at these three pictures. Now if I ask you, what is the shade of the tooth here? Can anybody comment now? Difficult, right? To say. Shade of a tooth hence cannot be said like A1, A2, A3. It's measurement of hue, value and chroma. Look closely. A2 enamel and A3.5 dentine is common to all three. But addition of bleach shade on incisal edge, addition of T shade on incisal edge, look at the amount of difference that it creates. Look at the amount of value that it does. Maybe this can be a case of a young patient around 17, 18 years of age having mamelons also. Maybe middle-aged patient like us or you all, few layers of mamelon worn out. Very old patient, lot of enamel loss can have appearance like this. All of this can be created and you don't need many shades in your hands. You can mix and match and play with them. Right? So you understood about hue. As I said, is like basic color. Value is the darkness to brightness. Saturation is the chroma. Right? So if I have A1 shade, A, B, C, D in shade guide and composite represents hue of composite. A, B, C, D is hue. There are four common hues found in natural tooth. Reddish yellow, whitish yellow, grey and brown. A is reddish yellow, B is whitish yellow, C is greyish and D is brown. A, B, C, D is four common hues found in natural tooth. Whereas 1, 2, 3, 4 represents value. Right? So by selecting A1, you are selecting what? Hue and value. Right? Which is very important for you to understand. These components are to be matched exactly in relation to the natural tooth in the patient's found. Right? Perfect. Now, final questions for us to understand. When should I use enamel? When should I use dentine? Always. Enamel forms the topmost layer, high value, you cannot scale. When should I use dentine? When the cavity is big and you want to mask something. If you don't use dentine, always you'll have the problem that the restoration becomes gray. And when should you use transparent shade in your younger patient on cutting edge or on the incisal edge in the younger patients? Perfect. Look at the shade guide now. I want you to pay real attention here. Everybody must have seen shade guide somewhere or the other. You tend to lose almost 50% of energy. The curing time should be doubled. But if you have a standard probe which does not have much taper, that gives you the maximum amount of intensity. Even after you raise it up to 8 to 9 millimeters, then you need to double it. So maximum focus on the tooth is possible if you have a standard probe. Right? Stay as close to the tooth as possible. But example, class 2 cases are already deep down. You cannot be very close. So remember that to double the curing times. These are small things that can help you to complete your polymerization. Last but not the least, polishing part, right? Very important. finishing and polishing is key to any kind of composite restoration, right? I have to do good finishing and polishing to achieve nice aesthetics, luster, gloss, shine, and also to avoid any kind of surface roughness or plaque adhesion later, right? Remember that anybody who knows how composite is cured on final layer, topmost layer, how it is done, anybody who, student who has gone through it, a concept called as oxygen inhibition. Oxygen inhibition. Can anybody explain this? What is oxygen inhibition in composite resins? The topmost layer of composite is always cured under a barrier so that during curing it does not come into contact with oxygen, because the surface of the composite which is with oxygen cannot be polymerized. It remains unpolymerized, and that depth of inhibition that is found out up to 100 microns, just 100 microns. Bonding agent penetration was how many microns? As I said, up to 10 microns. 100 microns is 10 layer of bonding agent curing every time. So that deep can be your depth of inhibition. That deep you can get the chances of composite being unpolymerized, and even if you polish it, how many layers you can remove, how many microns, maybe 10, 15, 20 microns, still the patient may come back with having discoloration. So how to avoid it? Do not allow the composite to react with oxygen while curing the topmost layer. Always cure your composite under a barrier, and that barrier should be water-based gel, example glycerine. Right? KY jellies are quite readily available. It is translucent, water-based. Cover it with on the entire composite, cure it, rinse it away. Light passes through it, right? Your depth of inhibition is almost negligible. You polish it, inhibition is not there. You tend to get very nice luster which does not discolor over a period of time. These are small things to be taken into account while you do good composite restorations. Right? Always remember my protocols. If I want to do adjustments, I follow red diamond burr followed by yellow. I don't use the blue, black and green for any adjustments. They are highly coarse. Red followed by yellow for any adjustments. Finishing. Polishing done with diamonds. I prefer diamonds. You can use silicon carbides. You can use aluminum oxides. I prefer diamond polishes. I don't have to use additional paste over it. My polishing steps becomes easier, as you saw in the video. There are polishing steps. Finishing, you saw two birds, red birds and the yellow birds. To finish composite followed by polishing. I prefer Opera Gloss from Iclard, right, which is a very good polishing system. One step diamond, right? Or there are many other systems which are available. You can also use the discs for adjustments from Eve, which are available, which are different color coded to make some adjustment, creating line angles and all those stuff quite easy with discs, right? So that's all from my side. I would really appreciate the effort taken up by all of you to be here and being really attentive. The point that I noted throughout my presentation was I did not see a sleeping face. Right? So thank you so much, and we move ahead with the Institute is one of the top 3 in India where this product is launched officially. It has not been launched elsewhere. Okay? So yesterday, I must tell you, yesterday it was in Rangoonwala where it was launched. Today it is your college. So second institute in entire India where this has been introduced. Right? So thank you so much, Dr. Shafe, for giving this opportunity. Please, doctors, join in for the cake cutting ceremony. Please, please. Hold it, everybody hold it. Hold it, everybody should hold it. Everybody should hold it. Everybody should hold it.
ठीक है।
थोड़ा नीचे थोड़ा नीचे थोड़ा नीचे बस
ये एडजस्ट करना पड़ेगा बाद में।
थोड़ा करेंगे ना सर।
Just switch on this light. No? Okay.
Perfect.
Yeah.
Okay. Good, sir.
Yeah. It's good. Maybe once I finish up explaining the materials that are displayed,
Okay.
then we can focus little more towards the.
Okay. On the general model itself. Yeah, sure.
Okay. So shall we start? Am I audible? Yes. I do need mic.
Okay.
That's fine. That's fine. That's fine. Perfect. So I have a model here which has a prepared 2-1 for composite veneering, right? We saw a video there about a composite veneering there, right? So we'll try to veneer this with composite. I also have a model which has a prepared class 1 cavity, right? I'll try to restore this with a new filling material that was introduced to the industry almost 7 years back, 8 years back, called as this Centurion N. Quite popular today now. It is quite easy, quick and fast, which is a basic filling material and alternative to amalgam, right? But it is tooth colored, quick to work with, and it is aesthetic. The best part is, I'll explain about this later when I do the posterior filling. But let's quickly jump to the veneer here that I have in my hands. Okay, so I'll try to build this up with instruments that I have here in my hand, which is Optrasculpt pad. If you look in the presentation, I explained about the instrument, which is Optrasculpt. So this instrument is single-handed, means there is a kind of tip here which is attached to it, which is a bigger tip called as 6 mm. Then there is a smaller tip as well, which you see here. I'm showing it, which is 4 mm tip. From 2, which we were discussing here, I will use this material for the veneer case. Universal shade, because most of the defect that you see here is on enamel. Hardly it has dentine involvement, plus there is no staining. So to restore such cases, single universal shade of enamel would do. So my preference would be to go with the A2. It is universal shade. But then if the defect was class 4 or the defect was having dentine involvement, I would have opted this and this. You see what is written here, A2, and then, so depends upon what are you doing, right? This is tetric N serum 2. Similarly, the older composite, if it was not older, the earlier version of tetric N serum, it is like this. It is available in this syringe. It is tetric N serum, what it is? A2 dentine, and then tetric N serum, what it is? A2 enamel, not enamel, universal shade. So this is older version, which is called as tetric N serum, and this is newer version, tetric N serum 2, right? So there is difference in handling, consistency, everything. What I am going to use is the tetric N serum 2 today, right? And also we got some special shades as I was discussing. This is some T shade, the incisor ledge build-up I was discussing. You remember? Use this T shade on incisor ledge, right? And transopal flow. Remember the bonding agent onto the tooth. Right, this is scrubbing. Advantage, this metallic tip, so scrubbing becomes much easier. That is why I prefer this pen. And whatever solvents that you see here, right, you should always have a chip blower and dispose that off, right, and then cure it. You should not be seeing any moving film onto the tooth before curing. So dispose the solvents away and then light cure it, right? So I light cured this for 5. I haven't done anything, and just look at the texture of the composite. Look at the gloss, the shine that you see right now onto the Composite, of course, you'll have to add a bit extra and to get that anatomy correct. In this phase itself, what you should do is that maybe we can make use of a brush, paint brush, right? And you can paint a bit. You look at the working time. How long can you play with this material? Still, we are in with LED, then finish polish. Of course, the final gloss, final texture, and everything will come in the finishing and polishing part, right? Right. Now we go on to the next part where we have the posterior restoration, right? The posterior part, which is the class 1 cavity, that is what you see here right in front. It is based on UDMAs, urethane dimethacrylates, polyethyl glycol 400 DMA and dicumyl peroxides, along with the fillers of alkaline nature, like you have glass fillers, alkaline fillers, that gives the alkaline nature to the material. 2:2 or 3:3 ratio. So let's get going. I have a mixing pad here. Shake, as I said, you have to shake and then tap it so that you have the filler particles of different sizes. So bigger and smaller filler particles are properly mixed and you get right proportion of the material. Furthermore, you take 1 scoop. So is this 1 scoop for me? No, this is not 1 scoop for me. Right? You have to wipe off excess from here. Whatever excess comes out, this is 1 scoop. Flat. And cover the bottle immediately because it has the light initiators also. So you have to cover this, keep it aside. I have a mixing pad. Put the powder in one corner. Don't put it in center. I'll tell you the reason why. Put the powder in one corner. Always it will give you an advantage to use the pad for mixing. Right? One corner. Then liquid, you should be taking 1 drop. How 1 drop? Not like this. Not like holding, air bubbles will be entrapped inside. So hold it firmly and drop 1 drop in center, right in center. See, 1 drop of liquid. Next step, the spatula is provided by the company. So I have the spatula here. It has got a bigger surface area compared to the GIC spatula, right? Hold this firmly. Hold this very nicely. Spread the liquid. You have to spread the liquid, very important. If I put the powder here, how will I spread it? Spread the liquid, take half. How much? And then mix it. What will spreading do? It will allow more powder particle to incorporate into liquid. And then take another half. Now you see this phase. How many people feel that liquid is finished? Everybody feels. The moment you put 1 more liquid, it's all gone. Now you have to actually spatulate with nice gentle pressure and force powder into liquid, and you will be getting a right mix which you can sculpt, which you can condense inside your cavity. There won't be any powder particle left. The entire game for this is mixing. Look what I'm doing. I'm incorporating the powder into here and I adapt it directly here. Right? You see this now? Still it is not set, right? So you have lot of working time with this material. I can make use of my other instrument to make the pits, fissures, right? This cavity is big. Maybe you would have to mix the 2 scoops to 2 powder together. Then you go ahead and build the tooth, right? So before deciding whether to go with 1 scoop or 2 scoop, you need to find out whether the cavity is small or cavity is big. And still there is a lot of time for the material to set. I can let the material set on its own, or I can wait, take the curing light and set it, right? So this is short. We have to mix 2 scoop because the cavity is big and then restore it, right? This is not in a set form. I will remove this out. You see, still not set, right? But then I would also like to show you the setting part of it. Once it is set, how does it behave after setting? Right, I'll take the light cure here just for your this thing. After you cure with light or you leave it for 4 minutes, how does it behave? It becomes rock hard. You cannot even scratch it out. You cannot even scratch it out. Forget about breaking it. It's rock solid hard. So it has got very high compressive strength, very high flexural strength of around 110 megapascal. That is why it is indicated for load bearing class 1, class 2.